Welcome, everyone, to today's program. I am Laura Dierda, Editor-in-Chief of Becker's ASC Review. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during this time. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Dr. Ken Cherry is the co-founder of the University Orthopedic Center in State College, Pennsylvania, as well as co-owner of the Advanced Center for Surgery in Altoona, Pennsylvania. And Scott Reed is the Vice President of Government Affairs and Reimbursement at Smith & Nephew. It's now my pleasure to turn the floor over to Scott to begin today's presentation.
Wonderful. Well, thank you so much for that kind introduction, and I think we'll start today at the top of the second slide, which is today's roadmap. And just by way of background, I've been at Smith & Nephew for about 4 years working on government affairs and reimbursement issues, a close emphasis on both the health policy side and the payment side of things. Before that, I was at Boston Scientific for about 10 years, really doing similar types of things. So a lot of focus on Medicare payment policy in many different fronts. So with that for today, I think what we'll do is, just at a very high level, my talk will only take about 15 minutes or so, but I wanted just to kind of start things off with kind of the broad high-level changes in the healthcare landscape. So many things going on right now, the shifting sands of how $3 trillion in healthcare spending occurs and the shifting incentives. We'll talk about that. Talk a little bit more about bundled payments and how that could be, it's very important right now, and how that's also shaping the landscape. We'll kind of feed that into the short stay total joint cases and what the latest on that, and then I'll just kind of end things with a few thoughts about what the future may hold in terms of some incentives and where things may be in a few years. So with that, let's just shift over to the next slide, and this is one of my it's a nice slide from Avalier, and I think it does a nice job at a very high level just showing how many different Medicare quality programs, alternative payment system changes are in the works right now. It's all kind of a trend toward, away from fee-for-service toward value-based payments. I'm not going to go through all of them, but this is just does a good job at kind of giving a high-level snapshot of whether it's payments to hospitals for outpatient care, to physicians, inpatient payments, and the like. There are so many different programs that are basically trying to incentivize improved care, trying to improve patient safety, trying to reduce readmissions. And this goes up to 2018, doesn't even show that under MACRA, there are some very significant physician payment changes as well that will consolidate some of the existing value-based programs for physicians. So anyway, won't get into that now, but just the idea here is just a high-level snapshot of all the different changes. So with that, maybe we can switch over to the next slide. And this just basically is a high-level view of and this is from the CMS side. They came out with this plan about 1 year ago where they are really trying to accelerate the pace of moving from a world in which there is fee-for-service to a world in which, for the time being, for the immediate few years, fee-for-service as the architecture, but much more rewards based on value, and then down the road in 5, 7, 8, 10 years, much more population-based management. But you can see that here we are in 2016, the expectation is there's already about 30% of Medicare's fee-for-service payments are in bundled payments, and obviously, as you can see, they want that growing all the more in 2018, and we'll talk a little bit more about some of those various elements. So with that, next slide, the Affordable Care Act, I can recall, all the different debates and the policy papers and the various hearings that came out of this, and so many different changes. At the end of the day, we're at about, as of 2016, about 15 million more covered lives. So many more people have insurance, but even aside from the expansion of Medicare, aside from some of the other sorts of major provisions, you have the new Centers for Medicare and Medicaid Innovation, and this is the $10 billion entity within CMS that comes up, kind of the incubator of policy ideas as it relates to new alternative payment systems, incentivizing quality, moving toward value, et cetera. And we have a couple of the, under the bullets here, some of the provisions under CMMI, the Bundled Payments for Care Improvement Initiative. Obviously, lots of talk recently about the Comprehensive Care for Joint Replacement pilot model, accountable care organizations, and any number of different specific provisions outlined on that previous slide, hack reduction, readmissions reduction, et cetera. So bottom line here is, aside from just the expansion of more people and getting coverage, you have a great many programs that are geared toward patient safety and improving quality. So with that, I'm going to move to the next slide and just talk a little bit about the Bundled Payments for Care Improvement Initiative. This is underway right now, and this is a voluntary program. Obviously, this many folks, if not everyone, kind of knows a good bit about this. You have over 400 hospitals, over I think 800 skilled nursing facilities. Many different healthcare providers are involved in this right now. This is a voluntary program. Next slide. And basically, at the end of the day, in Medicare, the CMMI group, they saw just how much you had individual providers making, submitting claims for fee-for-service. They really want to consolidate this all. The Bundled Payment Initiative is really taking, under BPCI, takes that 3 days prior to admission and then goes out either 30, 60, or 90 days post-discharge, although from what I can tell, most of the people are opting for the 90 days. And you just basically see how we're moving from each individual provider submitting a claim, getting paid, to a bundled payment environment where you really have, in advance kind of what's going to be paid. For the immediate time being, all the providers get paid their usual fee-for-service payment, but there's a reconciliation period at the end, and so depending on if you kind of come below or above the target price, then there may be a need to pay back CMS or get a check back from CMS. So anyway, we'll talk about that a little bit more. Next slide. So in terms of some of the particulars with the BPCI initiative, it's not just total joint replacement. Obviously, total joint replacement is the highest or the most highest volume bundle that hospitals are opting to take voluntary bundled payments for, but there are a total of 48 altogether. Basically, hospitals have the choice. They can pick 1 or 5 or 10 or all 48 bundles, and these are really all the high volume hospitalizations, pneumonia, heart failure, coronary stent insertion, total joints, all the relatively high volume ones. And I think that's how CMS is getting to its 30% of its fee-for-service getting paid bundle payments and steering ahead to almost 50% by 2018. There are 4 models overall that are available to hospitals and doctors that want to work together in these. And obviously, the upside is additional patient care improvement opportunities, and hospitals and doctors, if they, along with conveners, if they are able to basically reduce Medicare spending relative to a historical benchmark, they can share in that savings. And so the next slide kind of talks about those a little bit. I'm not going to get into the models too much, just know that there are various models. The Model 2 is the one that seems to be the most popular. That is 3 days before admission, 90 days post-discharge, and that covers all Part A and Part B, post-acute, DME, outpatient rehab, physician, hospital, et cetera, and any sort of readmissions that are connected to that. So that just kind of gives you a very high-level snapshot of that. Next slide. And you might say, well, how is the reconciliation implemented? And I think that as I look at the slide, the bottom part gets cut off, but at the end of the day, it's really looking at, and this is important too, we talk about all costs through the bundle. Costs really aren't, costs that individual hospitals incur per se. It's really more the collection and the complete aggregate amount of Medicare spending on different providers. So you could get your costs could be more than your Medicare payment, but the Medicare payment to the provider is what's going to get tallied up at the end of the day. So all these, depending on the length of the bundle, whether 60 or 90 or 30 days, and depending upon the model period, you're really going to compare that total amount of Medicare spending up against the historical benchmark. And so it all boils down to coming above that benchmark, that historical benchmark, or below, And if you come below, you're able to share in that savings. If you as a hospital under one of these BIPC programs, your spending is above the historical benchmark, you have to pay CMS back the difference between that target price and what the actual spending ended up being. So one of the other keys here is that with physicians, they can get up to 50% more than their ordinary fee schedule payments under BIPC. So with that, I'm going to skip to the next slide. And this is the comprehensive care for joint replacement. This obviously generating lots of discussion in the orthopedic surgery and industry and hospital world. This is a mandatory program. And unlike BIPC, what CMS wanted to do is they wanted to target those hospitals with either very little or no experience with bundled payments. And what they did is, and this is on the next slide, what they did is they basically said, let's, unlike BIPC, where hospitals and doctors are kind of coming together, often under a convener, this is going to go forward as of April 1st, and hospitals are going to be on the hook completely for, they're going to be subject to risk, but they will also be able to experience the upside that goes along with potentially reducing the 90-day episode of care spending versus historical benchmarks. And so they have the option, if hospitals have the option, if they choose, they are able to enter into gain sharing arrangements with physicians, home health agencies, SNFs, et cetera. That's really their option. And obviously that's happening a lot with BIPC right now. But if a hospital did not want to, they very much could just basically take on all the risk or potentially achieve all the rewards that may go along with lowering spending relative to the benchmark. Just a couple of details about CJR. The costs are reconciled annually. Again, the hospitals start off with all the risk and all the reward. And one of the things, too, that is a little bit different, BIPC right now, all those hospitals in BIPC, they sort of have the standard quality measures that go along with being a hospital. They have to, they have the complications rate and some of the other measures. But what's interesting with CJR is that CMS wanted to reward those hospitals that have higher quality, and higher quality being a complications rate after total joints, also the patient experience of care form, the survey that patients fill out when they get discharged, and there's a patient-reported outcomes measure that's going to be in the works. But basically, if you're a hospital and you do better on those quality measures, it makes it easier for you. You basically get to keep more money relative to that target price. And then if for some reason your spending goes over, you don't have to pay back quite as much. So basically for a $25,000 target price, which is kind of more or less in the middle of the road for hospitals over a 90-day episode of care, that translates, this enhanced quality benefit translates to about $375. You can get your discount rate down from 3% down to 1.5%. With better quality, and better quality kind of translates to more dollars. So I won't get into that too much, but just wanted to flag that. Again, next slide. This is just a quick map, really nothing more than showing that, the CJR is compulsory, it is not optional. 67 metropolitan statistical areas affected by that. Next slide. And then if you look at the cost drivers, everyone's thinking now about, okay, so what is going on within this 90-day bundle? Hospitals have traditionally been very focused, of course, on implants and device acquisitions. But now in this new world order of CJR, especially for one of those 800 hospitals, you're going to be forced to think about, hey, what sort of care is that patient getting when they're discharged? And we're going to talk about kind of some of the pathways and what that can translate to in terms of Medicare spending. But this just sort of shows the various components of that go along with a 90-day episode. So the next slide I'm going to go over, I think it's, I really like this one because sometimes people say, well, in the bundle, how do you get spending down? We're already getting a good price on our devices. There's not really much more that we can do. How can we possibly do this? And what's interesting is there is tremendous variation right now when it comes to Medicare spending on total joint replacement if you include the episode period of 90 days. This particular slide just basically shows how much the Medicare spending can vary depending on where that patient gets discharged first. So even though patients often will go to 2 or 3 post-acute care providers, be it home health or SNF or rehab, you can just see what a difference it makes in terms of Medicare spending when a patient on the far left-hand side you see HHA, home health agency. on average, if you're a patient and you've got a total joint replacement, your first visit after being discharged is to a home health, your spending is almost $15,000. But if you move over a couple of bars, and this is almost 20% of patients, if you get discharged to an inpatient rehab center, Medicare spending on average is about $27,000. And these numbers are a little bit off because it's a few years old, but you can just see how, depending on the first sort of provider that you go to as a patient after discharge, spending can vary radically, and it's not uncommon for a patient to go see 3 or 4. So this is where the variation is. Certainly, some parts of the country, Medicare spending after discharge for total joint patients is about $2,000. Other parts of the country, it's $16,000. So tremendous variation there. Next slide, please. So when it comes to outpatient total joint replacement, right now, as you know, Medicare has this particular total knees and total hips on the inpatient-only list. Medicare does not pay for outpatient joints. At least they do pay for unis, but they don't pay for total joints. They did have a proposal, interestingly enough, in 2012 to potentially add total knee replacement to their list of payable outpatient procedures, but they did withdraw it. I think if they ultimately did, if CMS did ultimately add total knee replacement to their list of payable outpatient services, they probably put it in the same payment category where the unis are right now. So you can kind of see at the second bullet point below, roughly $10,500 is what the rate is right now for unis, $7,800 or so for the ASC rate ultimately, if anything happened there. Certainly shorter inpatient stays are on the CJR horizon, and you may have heard that, when it comes to the second year of CJR, so in 2017, you don't have to have the patient stay in the hospital for 3 days in order to qualify for a SNF. As long as that patient is going to a SNF that has 3 stars or better, they can stay in the hospital for 2.5 days, for 2 days, potentially 1.5 days, still get that inpatient payment and still qualify for a SNF. So that's going to be kind of, CMS encouraging that type of activity. Next slide, please. Also on the outpatient side, CMS outpatient staff certainly know that some private payers are, many private payers are covering total joint replacement in outpatient centers, in ambulatory surgical centers. They know about that, but for the here and now, they are holding off on making changes to Medicare payment policy. And again, I think that if they ever did make a change, they'd probably put it in the same category, the same payment category that uni needs are getting, which is roughly $10,000 for outpatient and $7,000 for ASC. Next slide, please, and I'll be wrapping up in about a minute here. Just in terms of the growth in the outpatient sector, I think that you can see this is an advisory board slide. It's very helpful, I think, to show what their expectation is about the growth. And potentially, 2018 sounds very futuristic. It's only a couple years from now. They project almost 170,000 hospital outpatient total joint cases. And I think when they say in that context, they're talking about ASC and hospital outpatient departments. Next slide. So in terms of the future and what it holds, these are my predictions. I think that you're going to continue to see CMS policy on BIPC and CJR. CJR is good for 5 years. I wouldn't be surprised if they made some tweaks in the meantime. If there's substantial changes, they will have to do a notice of and comment rulemaking. But for minor revisions, I think they could just make those changes through an announcement. CMS may add, total joints to their list of outpatient and ASC procedures. Certainly lots of commercial insurers are doing that right now. Also in terms of the future, as it relates to total joints, much more payment tied to outcomes. You have the complications rate and readmissions measures right now playing a major factor in just how much, payments get adjusted, so that's going to be a key part. And also, you're going to have some sorts of, assurances, risk sharing. There's a episode of care assurance program that Smith & Nephew has as it relates to some of their wound dressings and kind of crediting hospitals if within 90 days there's a readmission. So I think you're going to see programs like that in the future. Next slide. And also there's going to be obviously a greater focus, not even so much on the long-term durability of implants, but the short-term 90-day episode of care. Many more protocols are going to be out there that really try to help hospitals with this, whether those patients are inpatient or outpatient. And I think you're also going to see some more partnering with home health agencies. The easiest way in a world of bundles and total joints to bring down that total Medicare spend is to have some of those patients that ordinarily would go to a SNF potentially go to a home health agency and be treated at home. That brings down the Medicare spending. So with that, I will close, and we can take any questions at the end, but I will turn things over to Dr. Ken Cherry for his talk now.
Dr. Cherry, you may be on mute.
Okay, how about now?
Sounds great, Dr. Cherry. Thanks so much.
Okay, sorry. So as I was saying, I thank Scott for introducing me. As you can see, there's a great deal of change that is occurring, and I think with change comes anxiety for a lot of people, but for me, change brings opportunity, and I'm as excited about healthcare, especially as it relates to joint replacements, my specialty, as I've ever been. I think the topic that I'm talking about is short stay, fatter future. My disclosure, next slide, is that I am a paid consultant for Smith & Nephew Corporation. Next slide. But our journey began rather serendipitously. We were looking for operating room time in one of our local hospitals, and we began performing outpatient surgery strictly because of a lack of inpatient time. We made the cover of this magazine in 2013 and essentially said a surgery center sending patients home happy in 4 hours. And we saw that our patients were having outstanding results and were very pleased with the level of care. And so for us, the future began in 2013. And one qualifier that I want to say throughout this talk is everything that we're going to talk about does not specifically relate to just an outpatient setting. I think the rules and the metrics and the things that we've learned align themselves perfectly for what you've just learned from Scott. And as we become more accountable for how we spend money and how we prevent complications, this whole thought process is applicable on many, many levels, and I think that it is absolutely the future of joint replacement. Next slide. So just to go back and go over some of what you've already heard, total joints we know are expanding at an unprecedented rate. The baby boomers are coming. The projected numbers, depending on where you look, the growth could be 600 to 700%. Currently, about 2% of total joints, not just unis, but total joints, are being done in an outpatient setting. You see the numbers there, about 1 million cases, total joints, with 17,000 performed as an outpatient. But next slide, a lot of the think tanks project that within the next few years, much as you've heard from Scott, can we bring up the next slide? This shows that the SG2 forecasts are predicting that up to 30% of total knees and 27% of total hips will be performed as outpatients within the next 10 years. So you have this extremely high volume, and a larger and larger percentage of these are going to be performed very likely in some sort of outpatient or short stay setting. And what's driving this is what we'll go into. As you can see on the right, there are a number of factors that we believe are driving this, and they're listed on the right. Next slide. So from a retail consumer point of view, as we've just mentioned, the average patient is getting younger. By 2016, 50% of patients with joint replacements will be less than 65 years old. This is a more informed population. They are looking for specialized programs, boutique programs, as you would. They're looking for minimally invasive techniques. They want quicker rehabilitation, quicker return to function. And along the same lines, as I'm sure most of you are familiar with, a lot of these patients now that are employed are faced with consumer-directed health plans. And as you know about the next slide, when you look at the trends with consumer-directed health plans, especially if you look at the second pie graph, 5 years from now, more than 60% of large employers are going to offer consumer-directed health plans as either their only plan or as a standalone plan. As you can see in the lower right, CDHPs jumped from 39 to 48% in 2014. And the crux of consumer-directed health plans are the providers are being grouped into tiers based on the cost-quality ratio, and the consumers are going to be rewarded through their deductibles by choosing those tiers that have higher quality and lower cost. And I'm going to show you an example of how that is happening right now in Pennsylvania. Next slide. So in the past, as Scott had mentioned, the old model was a fee-for-service. Now we are definitely looking at process improvement and value-based payments. And the future of medicine is these quality episode outcomes and care coordination. So if you look at the bottom of this slide, I would say that the current or the old hospital system probably had marginal quality at high cost. And as you know, the equation for value in a healthcare setting is a numerator of quality over a denominator of cost. The future hospitals will very likely continue to provide high quality, but at a high cost setting because of the bricks and mortar and because of everything that they need to care for all that a hospital setting takes. The short stay model, whether it be in an ambulatory center or an adjunct to a hospital setting, is going to or should provide high quality at a low cost. And obviously we believe that this is the most value-based system that we can see going forward and will fit in very nicely with the plan that the government has in store. Next slide. So as an example of this, this is happened currently in central Pennsylvania. Our particular surgical center, working with Blue Cross of Western PA, had a all-in cost for a total knee, not a unicompartmental knee, of about $13,000. You can see that was a $21,000 difference from our hospital. And in the first 150 cases with Highmark, we saved them over $3 million just by providing the same technique, same procedure, but in a different setting. We were able to save in just 150 cases $3 million. Next slide. So as a result of this change in saving money, the Highmark system has come up with what they call a diamond provider. And in the Highmark system, they would prefer that their diamond provider use Visionaire and Journey technology, which we'll talk about in a little bit, and be trained by a certified team. But in essence, what they want to do is keep their episode of care cost below a certain number. And they have seen with what we've done by using these high-tech instruments, we have been able to reduce our potentially avoidable complications and reduce our episode of care costs. So a diamond provider in the Highmark system, surgeon, if he or she meets these criteria, will be eligible for additional reimbursement up to 60% over the original fee they pay for a joint replacement. And at the same time, they're incentivizing their patients to go to one of these diamond providers by offering zero copays and zero deductibles. So we're going to see this trend where surgeons can be rewarded and patients, I believe, will be steered or directed to the most effective surgeons. So it can be a win-win situation. Next slide. And so this trend is happening all across the country. Amy Oldenburg, who is the head of Aetna Insurance, was quoted as saying, quality comes first when selecting doctors for their tiered networks, but then we select according to cost efficiency. So the trend is definitely increasing, and I think it is one that will continue to, you will continue to see rise. Next slide. So as we touched on a moment ago, in our setting, the technological advancements that are also driving this come, I think, some very highly technological aspects. The Journey 2 BCS is the only knee of its kind on the market. It functions in what we call a kinematic fashion and allows patients to get up and trust their knee more quickly. Visionaire is a technology, a patient-specific technology that involves preoperative planning and minimizes soft tissue damage, which again leads to rapid recovery. And it also has a bonus of reducing instrumentation and inventory sterilization costs, things that in these bundled programs will reduce cost. And then the last portion of this, the very last technology, is allowing us to put implants in that have the potential to last longer and not burden the healthcare system with the need for revision or repeat surgeries down the road. And I can tell you that Medicare has been looking at this Verilast technology very closely, because data in Australia has shown that this is far outperforming more conventional implantations. So technology is also driving this trend towards more rapid recovery surgeries. Next slide. Scott touched on this a good deal already. I won't belabor this system of care improvements, but to say again that if you can put implants in that work better, that rehab better, that perhaps have less complications, you are going to benefit. Our own hospital is looking at this right now. Under the current system with physicians using other types of implants, we would be in the hospital readmission reduction program, we would be subject to penalty, and we are preparing, not in an outpatient setting, I'm talking about an inpatient setting, we are preparing and aligning ourselves now for this 2016 test phase to do some of the things we have done in our ASC setting, to bring in some of the models and apply those to our hospital setting so we can prepare to get ready for this system of care improvements and not be penalized going forward. Next slide. On that original picture I showed, what else drives this? Well, from an ASC perspective, physician ownership is driving this. In a truly ambulatory center, physicians feel like they have increased control over their surgical practices. They can assemble highly trained, specially trained staff, which they think makes their day easier. Obviously, if you talk to physicians, they'll say it's convenient. The facilities are designed to meet their needs, and then they have the ability to participate in additional income with facility fees because they have a lower cost to operate. So there is financial incentive, there is lifestyle incentive, and we have seen this in our own ASC. This is a definite driver in the ASC setting. However, next slide. These very same benefits that we're seeing in an ASC setting, I believe, represent a tremendous opportunity to hospitals and physicians both going forward into this, the BPCI or some of these plans. As physicians and as hospitals, we're going to have to be more accountable. We're going to have to improve our patient selection, looking at things like BMI, nutritional status, but this will give us control over the patient's quality of care. Again, we should assemble teams that are trained and highly skilled. We still, by doing this specialty thing, can pick up all the conveniences of the ASC by, again, being more efficient with specialized team approach. The patients will be happier, the physicians will be happier, and then again, as you heard from Scott, and as we believe, by doing these things and doing these things well, applying these models not just to an outpatient center, but to a hospital center with a short stay or overnight stay, a bundled program, by reducing readmissions, by screening patients, there's going to be the ability to participate in the cost savings to the hospital that the physicians can participate in. And I think, again, with quality and quality of outcome, we're already seeing this where hospital centers who are doing good care are attracting large payer groups and corporations to bring their patients to their center from all over the country because they believe they will get a better result and at a better cost. So this model, while it was designed as an outpatient model, I think lends itself extremely well to efficiency and standardization of any total joint practice, be it outpatient, short stay, or inpatient model. Next slide. And I love this quote probably better than anything I've ever read. Brett Morris, who's the president of HealthNet Arizona, said it's like bringing Moneyball to healthcare. And I think that sums it up perfectly. It truly is Moneyball. It's looking at trends, it's looking at efficiencies, it's things that are long overdue, but really are quite simple and have been there in front of us for years. We've just not coordinated our efforts. So these things that seem sweeping and overwhelming are really not. Next slide. So what are the barriers? As Scott mentioned, insurance companies tend to follow the government. We know our government does not act quickly. Rich Berger, who is one of the renowned speakers in outpatient surgery said if this was pure capitalism, it completely makes sense. Unfortunately, as we know, our government no longer functions under a purely capitalistic system. However, we have seen change. Scott mentioned that unicompartmental knees are now being done as an outpatient. There has been discussion for total knees, and I truly believe that we're going to see that trend in the next year or so take place. So with the volume that we're faced with the economic burden we're faced with, and with the efficiency that these can be done, there's going to have to be a change. Scott touched on it briefly. I think probably the biggest barrier right now is home health agencies. We have to avoid readmissions. The readmissions will kill you in the bundled system, whether it's an outpatient or a short stay or even a 3-day inpatient. What we're finding is, as he showed on that one slide, inpatient rehab centers, skilled nursing facilities eat up a large volume of the bundle. In our area, we have a joint partnership with one exclusive home health agency that now covers almost the entire state of Pennsylvania. They have done wonders in our ASC program. As a result of their success, our hospital, which has a number of different competing orthopedic groups, has just partnered with them to do a pilot study where basically they help us with the screening of our patients, they help us prevent readmissions, and we're keeping our SNF or our inpatient rehabs down to almost nothing. Currently, better than 90% of my patients go home directly. Usually, even my inpatients are home within a day or a day and a half, and my outpatients obviously go home the same day. Next slide. So getting started. So all you out there listening say, well, how do we do this? How do you get started? Again, it seems like it's overwhelming, but hopefully I can show you in the next few minutes it's really not. A lot of this is common sense. A lot of this, you have the tools available to you already. It's just a matter of being organized and getting at this in an organized fashion. Next slide. So these are the things you really need to consider. How you're going to select your patients, how you're going to educate them. Surgical technique and implant choices, I think, are very important because they lend themselves to the middle one, which is pain management. Although there are multimodal pain management techniques, better surgical techniques that cause less physical harm to the patient, allow more rapid rehabilitation. And then again, as I mentioned, find a home nursing agency, find an agency that is reliable, that you can work with, that will work with your patients and work with the physicians and prevent emergency room visits, prevent wasted money that is currently going on all over the place. Next slide. So patient selection obviously is key. These are, you want to avoid major complications. 90% of major complications tend to occur within the first 4 days. So that may scare you and say, well, if we're sending them home, why not just keep them for the first 4 days? But as you can see, the second article here was an article by Dr. Berger way back in 2005, who's done hundreds of thousands of outpatients. At 96% of his patients go home the same day, and 3 readmissions, none were related to early discharge. Next slide. But that comes from patient selection, and patient selection takes a very holistic approach. You have to look at the physical aspects, the mental aspects, and the social aspects of the patient. And again, it seems like a lot, but when we get into it, it's really pretty simple. Next slide. From a physical standpoint, these are some of the things that studies consistently show predict longer length of stays. Total hips historically have had longer length of stays than knees, but we're seeing that change with the advent of direct anterior. Advanced age, greater illness, ASA 3 or 4 categories, and then people who have cardiovascular comorbidities or renal disease. Next slide. Weight is a major issue. When you look at patients with high BMIs, especially over 30 and extremely over 40, these are the patients that have wound complications, infections, higher revision rates, and they're often, believe it or not, malnourished. And so I think we, going forward, are going to have to be better about counseling and helping these patients, not just denying them and saying you can't have surgery, but helping them understand why they're at risk and enrolling them in programs that help on life and diet modifications to improve their situation prior to surgery. So again, it's an accountability thing, but it's not that hard to do. I can tell you we do this in our own area. We help patients get enrolled in either a weight loss or nutritional counseling, exercise counseling. We tell them if they can come back and demonstrate, perhaps not even a total loss of weight, but a weight change in class, we're willing to start negotiating with them to perform their surgeries. But thinking of these things, are they diabetic? Is their sugars controlled? Is their blood pressure controlled? Do they have sleep apnea? Not dealing with these after the fact, but having a team that sits down and looks at these things and helps screen these patients preoperatively. Again, whether it's an ASC or an inpatient, will help tremendously in a bundled program. Next slide. Hemoglobin is also a predictor, but the thing about this is something that new modern surgical techniques, as we've touched on, minimally invasive, patient-specific implants, without a doubt have less blood, and then some new modern pharmacological agents like tranexamic acid, reduce bleeding. So these are scientific things, but again, team approach, protocol-driven, can reduce things that have been the bane of our existence forever. It's virtually unheard of in most centers now to see transfusions necessary for total hip or total knee patients if you have even a rudimentary blood management, preoperative management program in place. Next slide. So again, the ideal patient, this would be my ideal patient. I love to play tennis. My knee hurts. My wife is at home. Social can help me. When can you do my knee? Well, I would say, sign you up. You can come in tomorrow. I'll find time. Next slide. But really, these are the ideal. You know, not obese, healthy, favorable anatomy, well-managed expectations, motivated to go home. And then again, they need to have a favorable home environment. And they need to be aware of everything. Their medications, you should assess their functional ability. And again, this is not just outpatient. This works great for outpatient, but I find in central Pennsylvania, everything I do for my outpatients, I do for my inpatient program. And with a model like this, I've reduced my length of stay from 3 days to 2 days to 1.2 days. So even my inpatients, virtually 80% of them are going home within a day. So it's not that hard to do. And again, by applying these principles, they benefit everyone. Next slide. This is what you want to avoid. You want to avoid patients with marked limitations in preoperative function. You want to avoid patients with marked comorbidities. Some of these health assessment scoring sheets and wellness scoring sheets with low scores you want to avoid. Greater than 4 allergies is also a little clue. Is the patient realistic? And then again, fibromyalgia, chronic pain, people who've had multiple surgeries may not be good candidates. So they're not all absolute contraindications, but when put together with the whole picture, things to think about and counsel these patients and prepare them that this may not be as easy as they thought it, and maybe they should rethink alternative treatments. Next slide. So again, the key takeaways are you want healthy, motivated patients who are mentally strong. You need to have an excellent support network at home. A team approach we've found is critical to have teams and protocols, and to sit down and review these protocols very frequently, at least monthly, to see where you're going, what you've done, what you can learn from them all. Next slide. So we have about 15 minutes. I'm going to go through some of my experience a little more quickly because I maybe leave room for some questions. But in our experience, next slide, we started our Advanced Center for Surgery in 2012. We are the only freestanding surgery center approved by the Department of Health in Pennsylvania to perform total joint arthroplasty. We are now assisting them with licensing other centers in Pennsylvania. Our ASC center is truly a freestanding center. We are not affiliated with a hospital. Our patients go home within 3 hours, and it's because of our highly advanced protocol, things that I've touched on, patient selection, perioperative management, and a very strong home nursing agency. Next slide. These were our demographics. Again, pretty standard. We've had some high BMIs, but mostly ASAs 1 and 2. Next slide. The case demographics, You can see 151 total knees, 64 total hips, 8 hip resurfacings, a few unis, but pretty big surgeries, really. These are not cherry-picked unicompartmental knee surgeries. Next slide. As I said, this was our recipe for success. We used what I believe is the most highly functioning kinematically correct knee on the market. We use patient-specific implantation. I use this both in my inpatient and outpatient center. It minimizes soft tissue damage. It allows people to be up walking within hours of the surgery. And then we have a very strong patient education program. Next slide. When we made this article, the part of the article which is available, we had our do's and don'ts. Next slide. And so this busy slide, and we won't go into all of it, but our do's, and this was our do's and don'ts. Again, this is available in the article, but we broke this down. So some of the do's, next slide, are you want to have universal protocols. If you have physicians, you can't have physicians involved in this who want to do things their own way and be cowboys. If you can't have Dr. X wants a certain pill, Dr. Y wants a certain pill, or uses a certain bandage. This has to be an all-in, all-agreed-upon system. That's how it works. People don't fall through the cracks. If you want to bring changes to our group, we're willing to sit down and listen, but you have to bring us evidence-based protocols or medicines to say why you want to use a different pill or a different bandage. You can't just say, well, I like this rep or I like that. So I would strongly recommend that you organize teams and that you get physicians to buy into this and leave their egos at the door. And they'll see the benefits, but you can't have broken up protocols. It has to be universal. Next slide. Again, we touched on this a lot. You've got to screen these patients appropriately. Our home health agency makes a home site assessment on all of our outpatients and tells us that their home environment's safe. They have the power to veto our surgery if they don't feel it's safe, and then we'll do them as an inpatient. So you have to screen the patients, as we've talked about. Next slide. Again, I've said this repetitively, but probably the number one thing other than the implant and the surgical technique is a dedicated home nursing agency. They help establish our programs. They make our patients' care seamless. They are our eyes. They avoid readmissions. They do not tell patients, oh, your knee's red, you better go to the emergency room. You might have cellulitis. You might have infection. They don't ever use those terms. If there's any concern, 24 hours a day, they reach our practice, and the deal is we will see that patient within hours. So they help us monitor our patients, but again, in this day where we're going to be penalized for somebody coming to the emergency room and getting admitted overnight because they had quote-unquote cellulitis and discharged the next day, having a dedicated home nursing agency who knows what you want will dramatically reduce that. Next slide. Again, you have to plan for the procedure. You got to know who's responsible for if that includes the patients. Even if they're going to go home the same day or the next day, you got to know who's going to be home to help take care of them, and you have to evaluate their environment. I have jokingly said I think our outpatient program is better because we have people waiting for our patients when they go home. When they go home a day or two later, they're kind of on their own. But with our home nursing agency, we've planned things out. Patients know what to expect, and they're there very quickly on their discharge. Next slide. Again, you have to educate all of the members of the team, and my chairman used to call this KISS, and it doesn't mean the KISS like you see on the screen. KISS means keep it simple, stupid. You have to explain things to patients on levels that they can understand, not necessarily on levels that we as physicians think they understand. Next slide. So our education protocol, we try to explain the pathology, explain the procedure, discuss what we're going to do for pain, and then be available. Next slide. I find explaining the pathology is very easy with handouts. I use a great deal of handouts. This is what I take into my room every single time I'm with the patient. I use models showing normal and abnormal knees, a nice picture book showing normal and diseased knees, and then these handouts. It's amazing how many people think that these surgeries are chopping their knees apart, and when you explain how exact and how precise it is, next slide, how you are going to use technology with an MRI to design and build the knee preoperatively to fit them more precisely, as opposed to figuring all this out and trying to make some arbitrary size fit them intraoperatively. They just light up and they're on board. They're excited. They understand it in simplistic terms, and they look forward to getting better, and they're not so afraid of the unknown. Next slide. Smith & Nephew does a great job of providing this. These are some of the print materials I use. That the one on the right, the knee replacement, I probably use 25 to 30 of those a day. Again, showing patients what a normal X-ray should look like, what an arthritic knee is on there with as well as a normal-looking knee, and then what the procedure looks like. And then you give them that. I mark it all up. I mark their X-ray up. You give them some of these journals, and again, it allows them to go home and think about it, but they come prepared and they're ready to take on the surgeries. Next slide. We won't belabor these. These are probably more interested to your surgeons, but we call it a multimodal pain protocol. This is very common in the literature with certain tweaks, but it's covering all aspects of what can cause pain, not just requiring somebody else to deal with the pain. Next slide. You have to be available. I tell my patients, I exchange phone numbers with all of my patients. I give my patients my home phone number, and that may cause some physicians some anxiety, but I can tell you that has never been abused by a patient. I tell my outpatients, if they need me anytime that night, call me. I know Dr. Berger does the same thing out in Chicago with very similar results. Patients appreciate that. It makes them feel empowered, and they're just much more relaxed, and they're less likely to bother you with trivial things. Next slide. So we'll go through these quickly. This is just our OR setup. Again, I take all that information into the operating room. It prepares me what will happen. We can go through these slides pretty quickly. Next slide. We use a minimally invasive technique. Next slide. Probably one of the most critical things with using Visionaire technology is I don't use a tourniquet. Anyone who's had their blood pressure taken, even for a minute, and know how bad that hurts on your arm, imagine having a surgery on your knee where that thing's inflated for an hour and a half or 2 hours. It causes damage. It causes pain. Again, some of the modern surgical techniques, by pre-designing the knee, having things pre-made, allows us now to do these surgeries without the tourniquet, and it's just another way to eliminate pain. Next slide. These are just a couple of pictures showing us going in, or this is just, I'm sorry, I jumped ahead. This is an article just saying that patients do better when no tourniquet is used. Next slide. Next slide. This is just showing our approach, and you can see that there's no tourniquet on this. Next slide. Next slide. Just a very bloodless field. Even though these can traditionally be bloody, this is the approach I do. Again, we don't need to go into this. It's just a better way to do the knee operatively. Next slide. And again, another article saying how much better patients do when, not only for pain and range of motion, but their risk of blood clots and thromboembolic events, which can be serious, are dramatically reduced when you don't use a tourniquet. So the spin-offs of this are better for the patient in so many ways, and it's not that difficult to do. Next slide. We can just, again, very little bleeding. Next slide. Again, you can see great exposure, no bleeding, which traditionally is bloody surgery. This is just showing our implants, the Visionaire blocks that help us do this surgery with minimal technique. Next, that's the trial knee in place. And then the next two slides just show us checking the range of motion of the knee, full extension. Next slide. To full flexion. Again, this operation usually takes less than an hour. Post-operatively, we avoid narcotics. Narcotics cause obtundation, nausea, constipation, and we look at what we call quality of recovery. We're very interested in patients having a quality recovery, being alert and able to interact with their loved ones and with their therapist and not be a zombie. Next slide. Our patients, again, very typically inpatient or outpatient, are up walking within 2 hours of the surgery without a brace. That gives them a great deal of confidence. They're not painful, they trust their knee, and then they're ready to get on with their life. Next slide. So these are our results in our ASC setting. We had a 98% satisfaction rate. A couple patients that were not, one was overwhelmed, one had too many steps. We've now used our home nursing agency to screen out patients that have too many steps or don't have a good support network. We had one readmission. A patient felt weak and no diagnosis was made. Patient was discharged. 2 falls. They were actually related to truly accidental falls. 1 infection and 1 PE was in my partner, who at the time was using a tourniquet and who's now bought into the full program and does his knees, as we all do, without the tourniquet. So I feel like our results have been outstanding and mirror what some of the other people across the country. But very low readmission rate, very high satisfaction rate. Next slide. So thank you. That leaves us, I guess, about 5 minutes for questions. I hope I didn't get too technical on you, but as I have mentioned, I think this is an extremely exciting time. There's tremendous opportunity. This does not have to be done one particular way, but if we make patient care the center of our attention and we screen and follow patients appropriately, I think this bundled program system will be an opportunity to succeed. Thank you.
Thank you, Dr. Cherry and Scott, for a very informative and enjoyable presentation. We will now begin a short Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have for Q&A. So I think the first question I have here is, do services provided post-discharge get billed to the Medicare or to the hospital or ACO that the bundled payment was sent to?
This is Scott. Yeah, sure. I think when it comes to bundled payments, the thing that's interesting is, even though it's kind of a brand new way of trying to keep spending within, the historical spending levels, the ordinary billing that occurs now happens. So you continue to have, all the continue to bill, and there's no billing in ACO. You just bill to your Medicare contractor the way you ordinarily would.
Excellent, thank you. The next question I have is, for the April 1st, 2016 for the CJR program, is that still the effective date, or are there delays to that date?
We certainly know that there are some in Congress that want to delay it beyond April the 1st, but April the 1st is the effective date as of now, barring some unforeseen changes. But that's the go-forward start date that we're operating under.
Absolutely, absolutely. So you would still plan on the April date then? And
yeah, would still plan on first, yes.
Okay, perfect. All right, Dr. Cherry, I have a question for you. Let's see here. Let's see. What is your blood transfusion protocol, and do you have blood available?
We do not have blood available. We have not transfused a patient in any of our settings in probably 4 years. We do use tranexamic acid. We give a gram pre-op and a gram prior to wound closure. Even without a tourniquet, we see blood loss of 50 to 75 cc's. Again, if a patient has a very low hemoglobin preoperatively below 10, we get them into a hematologist to use Procrit or use some other erythrocyte potentiating agent. So we kind of screen them out preoperatively, but we have not required transfusions in quite some time. We also don't test blood count if we don't feel it's necessary. So ordering unnecessary lab tests just to say you did it, the patient's not symptomatic, not hypotensive, we don't typically order routine CBCs and lab tests.
Okay, excellent. Thank you so much. And I want to thank our presenters again for an excellent presentation, and to all of you for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.